Parakan sir, relayed from the OT. I request Dr. Jyoti Swarup to kindly chair the session. Dr. Apurva will brief about the case.
Hello. Hello.
उसको जब लगेगा okay with ready there whether they're ready. Hello.
43-year-old male presented with complaints of right ear discharge since 3 years. A history of presenting illness. The patient was apparently asymptomatic 3 years ago when he developed ear discharge, which was episodic, insidious in onset, gradually progressive, mucoid in nature, moderate in amount, non-foul smelling, which was aggravated in winter and relieved on topical medication. There was no history of recent fever, URTI, or nasal complaints. Endoscopic finding of the tympanic membrane is of this. Audiogram shows right-sided 26 decibel hearing loss and left-sided 8.7 decibel hearing loss.
Yes.
So we have the details of the case. I request to shift to the OT. I suppose Dr. Khan is ready for the case. Patient has already been induced and kept ready. As you can see, Dr. Khan has already connected the Endohold.
Hello.
Over to you, Dr. Khan.
Hello, Devi.
Good morning, sir. Can you hear us, sir?
Yes, perfectly. I hope
Fine.
the picture is there on the screen.
Yes, sir.
Yes. So first of all, thanks a lot, Professor Devi Prasad, for giving this opportunity to demonstrate the concept of two-handed endoscopic ear surgery. And Professor Devi has come all the way to Talegaon to see the techniques and all. And today, instead of speaking much theoretically, we will directly see how it can be done. So I have already mounted this. We'll be talking about this in the lecture also. It's a simple concept. The idea is you can hold the endoscope. You can hold the endoscope with anything. It can be a fixed, just like this, an endoscope is held. But it is of no use for the any ear surgery or any type of endoscopic procedure, because you need to simulate this hand, up, down, these actions. These all actions are simulated in a simple way. This is not a simple endoscope holder. This is a dynamic endoscope holder. So what it has got? So this vertical arm where it is mounted, and then there is an horizontal arm. This road. Okay. So wherever you want, you can go on in this plane, that is X and Y plane. Now for this, that is a gas spring action. Wherever you want, you go. Keep the endoscope, that's all. If you want to fix it, fix it. So this is an horizontal gas spring arm for the up and down motion. Once you are taking endoscope nearer to the area of your surgery, then you need a small fine movement. So you have a rack and pinion mechanism where you can take the endoscope smoothly in and out. All these actions are very, very much important whenever you want to do not only the ear surgery. We are developing a concept of exclusive two-handed endoscopic ear surgeries. We don't use a microscope at all. We don't have a microscope in our OT. So everything is done by this exclusive endoscope holder. Later on, I will show you the concept of just as also. When you want to shift from the microscope to the endoscope, you have a just as. So we will talk about that. So simple, these actions, this action, this action. So these all actions are simulated. You must be familiar with your microscope. The actions are the similar to this of microscope. Only difference is the endoscope is attached. Here, this is meant for the Karl Strauss endoscope. If you have the other endoscopes, you have a magic clamp too. We will show you later on. So the idea is to hold the endoscope to do the typical ear surgery like the way you do with the microscope, that is with the two hands. So now attaching the endoscope. Please interrupt me whenever you have any query, because idea is to take this concept forward. It is not that I am just operating and I should go on operating and you should say, oh, so nicely done. No, each and every person in the audience must do and enjoy this endoscopic concept of ear surgery. Okay, so feel free to disturb me.
So I request the delegates to pass on a slip of paper the queries that you have to the chairperson, Dr. Jyoti Swarup. Sir will be happy to carry forward your question to the operating surgeon. Thank you.
So the endoscope is attached. Now you are ready to do the endoscopic ear surgery. The camera will be mounted here, and the rest, everything you know, you are going to see on the screen and you are operating. The beauty is that whenever you want to take near, take it. And when you are near to the ear, what you need to do is smoothly go in and out. That's all. This is a 4mm endoscope. I will be using the 3mm endoscope and with the two hands. So wherever you want, you can keep it like this. I do all procedures are transcanal and my maximally mini end oral incision. I never go for this post oral incision. I can manage everything with the transcanal and the end oral because I have the panoramic view with this endoscope. Okay, so I hope the idea is got clear. Just one or two words about why only this endoscope holder. Because we are developing the technique not for the ear. We have developed the all tools and techniques for the endoscopic ear surgery. Now we are developing the tools and the techniques for the two-handed endoscopic oropharyngolaryngeal surgeries. So the era will come. This future ENT surgeons, the budding ENT surgeons will see the way we have learned the microscopic techniques of larynx and the ear, how it is changing smoothly to the endoscope. So you need to develop a different types of tools. So feel free to visit our demonstration stall is there. So to see the innovation, because just developing and doing the endoscopic ear surgery with a holder is not a concept. Why people can't do it by just seeing on the YouTube? Why? Because you need to understand the concept. You need to understand the tools developed in and around it. And you need those instruments like angled instruments, those auto shields, that is called a protector. So all these things are needed for this. And then only you can smoothly carry out the two-handed endoscopic ear surgery. So just I will take one or two questions and then I will get washed.
Sir, can you explain a little bit about the position of the head?
Position of the head. Similar, no changes. Okay. See this. This is the typical position. The way you do the microscopic ear surgery, there is no change. My endoscope holder is mounted on the opposite side. I will be sitting towards the operating ear. Okay. So head is rotated to the opposite side, typically the way you do for the microscopic ear surgery.
What about all cases you do under GS, sir, or local also can be done?
Almost all cases I do under general anesthesia. Hardly 1 or 2% cases I do under local anesthesia if the patient is cooperative. But in such cases, I give a good sedation, ask patient anesthetist to give a good sedation. And even I ask, many of the time the patient moves its head. So ask my assistant to support the head when I'm doing under the local anesthesia. Okay. But now I was just talking to the resident here. Now, when the anesthetists are so good, can you show that 86/50, fantastic hypotensive anesthesia? Only some cost is increased, but they give a fantastic anesthesia. So why to worry about now for the local anesthesia and all? Yes.
Fine.
Any more question?
You can pass on to me.
Hello.
Yes, sir. Continue, sir. Continue.
Okay, please. Any questions? Otherwise, I will just go for the washing. Yeah. Isko.
Sir, enlighten us regarding the use of instruments separate from microscopic instruments, what we use.
Instruments?
Yeah.
Yeah.
Same instruments you are using, or is there any change?
Yeah, that's a good question. So many of the instruments are just for the good canal, just for a good, nice, wide canal. You can almost do your surgery with a routine ear instrument. But certain instrument needs to be bent when you want to address the area of the retrotympanum, protympanum into the attic. So I have bent those instruments. I will show those instruments, how we are using. So you need those bent when you are working with the endoscope and with the two hands. Okay. Yes, I will just go for the wash up. We have a cover, no? मुझे लगता है endoscope लगाएंगे. I give that endoscope. I will put the endoscope 3 mm. Yes. इसके ऊपर कैमरा लगाओ, लाइट लगाओ, and then through the hole you can put the cover. Okay, I'll just wash. Hmm? 8 number? Yeah. Hmm? No problem. Huh? Yeah. Encore will be better. Encore this. This one? Oh, yeah. मोटा है, but it's quite मोटा. 8 number, no? Striker people are there? Striker
sir.
people, huh? So continuing the discussion for the endoscopic ear surgery, number one important thing is that you are seeing at the monitor. So what you need is an excellent camera. Minimal requirement is to have 3-chip or it's high definition cameras. If you are not using that, then it's very difficult to enjoy the endoscopic ear surgery. First, the camera and camera cable.
So can you just show where is the monitor is kept and
Yes, please show that monitor. Show that monitor. Okay, it is just in front of you. That is opposite side, exactly opposite side.
yes.
Yeah. Striker is a good camera because I'm using it for the last 1 decade. I have a 11888. I think here it is. I don't know where is this guy. बहुत बड़ा है, ठीक है. Just take this one. इसको एक बांध दो इधर. Just tie something here. If that striker man is there, that person. Take this one. So here is a 3 millimeter endoscope and striker camera. ये light इसको बंद करो ऊपर. And I need a table little bit up. Striker, yeah. Oh, which camera it is? 1688. So it's quite advanced. I am an old man, so I'm using a 1188. But I tell you, striker is a quite good, excellent camera. I don't know. That's why इसके लिए बोला मैंने इसको start करने के लिए. Okay. Right side. Okay. Because 1188 has got the A, but you have added some different function here. Yes, I think it's still there with the white balance continuous. Okay. Yeah. Sorry, just 1 minute. Zoom out. Yeah. Oh, can sister, can you give me some cleaning? Yeah. No, just cleaning for because.
Do you use any defogging agent or?
Yes, Savlon, just simple Savlon. But I hardly use it because for when you are using the two hands, the left hand is having the suction and that takes care for the fogging. I will show you that. Huh?
Okay.
So let's focus for some time. Spending a time to learn the camera is also good because that's a future only. The cameras going to be very brilliant, 4K monitors and then 3D cameras. So many things are going to happen. Yes, it's quite. Okay. Can you make some table up? जाने दो थोड़ा सा और थोड़ा सा. Yes, better. But ठीक. And just take little bit screen here. थोड़ा सा इसको इधर ले. हाँ थोड़ा सा. Yes, better. So first thing is to do the middle ear endoscopy. Suction, please. Please feel free to ask the questions because asking is knowing. I will go on talking, but if there are
So
very
anything like the selection of cases, like depending on the extraordinary canal size, shape, and all. Anything?
No. For the endoscopy you are saying?
Yes, sir. Yes, sir.
Okay, so for me, there are no selections because I don't have a microscope. So I have to do everything with the endoscope, normal saline. Yes, but if at all, I can select the cases, I categorize the cases depending upon the external auditory canal diameter. If it's a wide enough, I'm using the 3mm endoscope. So then I do a procedure by the transcanal way. Give me with the normal. And if it is a canal is narrow, then I take a mini end oral incision. Okay, that is what is important. Now here, there are the hairs, so we have to take those hairs out. Otherwise, pre-operatively, I take those hairs with the wheat cream. Okay, so these hairs usually touch to the lens and blurs the vision of your endoscope. So you have to remove those hairs one day prior. So no problem. We will cut here.
Yeah, the color is little yellowish, sir. How is the picture on the monitor there, sir?
Monitor, it's quite good. Huh?
But here we are getting more of yellowish tinge. Not the natural color.
Let's go inside and see because if whether we need an adjustment because I'm having a good picture on the screen. Huh? Normal, sir, God's peace.
I think you have to adjust color here because in the
See, these are the hairs. Let me just clean those hairs first. Suction बहुत छोटा चाहिए मुझे. हाँ मुझे. I can see the overhang there, but there is no problem. You can manage with just with the one rotation. You can manage. This is the fogging. मेरे आपके कोई भी instrument मत दो मुझे. Don't give your instrument. Just give my instruments. Okay? हाँ, small. Yeah. हाँ. आपके कुछ भी मत दो मुझे instrument. ये आपके है सब. आपका कुछ भी मत दो because just because all big instrument I need this one. इसका adapter लगेगा. So if this fogging is there, what you will go on doing? You are taking endoscope in and out again and again. Huh? Adapter लगेगा पहले. रफिक आलाय का चल गया चल नाही तर नंतर लावा म्हणत. Adapter लगेगा. Give me the adapter. So just with the suction, there is no need of any fogging. So first thing, I will clean those hairs, and then I will take a Tarabishi stitch. Let me go. Is now the picture good there?
No, sir, it's too yellowish and
Oh, okay. Because I can have a good picture here. You can even, can you show the screen there? Screen ko dikhao. See the screen, because I am seeing the very good picture here. Huh? Give me blade.
with the
15.
extra. Yeah.
You can see the picture.
Color is okay, sir. Little bit fine focusing maybe.
Okay. Oh, we will see. We will do that. This is very, very small steps, but very important for the ear surgery, because those hairs makes a lot of trouble for the endoscopic. Just God's peace, clean karne ke liye. So take a time to take those hairs. Usually this 15 number blade gives the lot of abrasion, so use a perfect angle to clean that. Okay, otherwise better is to just apply a wheat cream one day prior and take those all hairs out. I'm just taking out those hairs. Let's go near. Still few hairs. Looks better now. Now somebody has asked about the how you select the cases. So to answer that, when you are just pulling the pinna like this and you are not able to see the whole eardrum, means there is a canal is tortuous. So in such cases, be prepared that you need some good exposure. So you can go for the end oral incision, but here it's no problem because it's just simple type 1 and we can manage that with the angle. So pre-operatively, you can decide those things. This is all fogging, okay? So for such things, you don't need anything. Just put a suction. Can you see that?
Yeah.
Yeah, so no need of taking in and out again and again. Give me for the Tarabishi stitch. So now pulling the things, that is pulling the pinna, because I will be using the 2 hands. So I need a fixing of this. So I will take a 1 stay suture from here and pull the pinna, so that, see that now whole of the eardrum is in front of me. If I leave that, it is blocking the vision. So you have to pull like this. Okay.
Like we do, like pull upwards and backwards, or just
absolutely right. What you do in OPD. So here you need a complete stay suture.
Can you just show that how?
Yes, please. So first little bit of endoscopic anatomy is there. You have just heard about that, but here for the residents tragus, I will be harvesting the cartilage from this anterior wall, posterior wall, superior wall, inferior wall. This is a right ear. Okay, this is a incisura terminalis. We take an incision here for the end oral incision. Okay, if possible, in the third case, I will show you that. That's a mini end oral incision for that. So again, anterior, posterior, superior, inferior. By pulling this, you can make the canal straight and you can see the whole eardrum. Once again, now we will go inside and see. Need not to worry about this fogging. It's a troublesome for the single-handed people. You go on taking in and out, but here there is no problem. Just a suction and that will vanish. See that? We need to clean all these things. See that? Okay.
Yeah.
Beautiful. I can see a beautiful picture now here. Okay. Hope so. You will be having a good picture there.
Yes, sir.
Yeah. Suction, please change. I need. अच्छा इसको clean करो. Clean करो.
Sir, do you infiltrate any saline with adrenaline? Or...
Yes, I am going to show that because you have to do the use xylocaine with adrenaline. Usually I use that. You don't need a xylocaine, but it additionally helps. Even my anesthetist says that you use xylocaine because locally it helps.
Post-operative pain.
Yeah. Clean it. Put a Rafi kala kare. Okay. So again, we will just go inside with a fine focusing. See how nicely it goes. That is why it is needed. Okay. See that now everything is in your view.
Yes, sir. Yes. Sir.
Okay. Give me the suction again. Keep your suction here because I'm pulling the yes. So again, the anatomy, anterior wall. This is anterior orang, posterior wall, inferior wall, superior wall. I can see the lateral process of malleus.
Yeah.
Shrapnel's membrane. Perforation is in the anterior, superior, and anterior inferior quadrants. It's a medium-sized perforation. I can see the tympanosclerosis. Whenever there is some vascularization that suggests active tympanosclerosis is going on, so we'll spare almost try to remove whole because I can see some patches here too. So we'll take it out as much of TM as possible, and I will be doing almost raising flap to 70 degree. Okay, you can see the tympanosclerotic plaque here.
Yeah, yeah.
And you can see the vascularization. So that suggests an active tympanosclerosis going on. Okay. So here is the annulus overhang. It becomes very tough to operate here with the routine instruments. So that's why you need the angle instrument. So let's go. Okay. This idea is clear for this?
Yes, clear.
Yes. Let's go for now just rotating little bit. You can see the whole superior part. Okay. Right.
Fine, fine.
Yeah, okay. So now, before first we will take the Tarabashi stitch, then some infiltration. I want to demonstrate all simple steps because all the residents are there, and just give me the Tarabashi stitch. Again, no, I am not interested in fight with the what is best endoscope or the microscope, single hand, two hands. The thing is that अरे क्या किया इसको सब पूरा अटक गया ये. सब धागा ये हो गया उसको निकालो. So instead of going into the controversy, only idea is that how simply, how beautifully you can do the surgery and what best you can take out of the all tools. Okay. And what I find for the budding ENT surgeons, endoscope is really a boon for the learning. It has revolutionized the nose, and I am definitely sure that it will revolutionize the ear and the throat too. And then the one era will come, I am hopeful, that one ENT surgeon, one endoscope, one excellent camera, that's all. No need of anything. But believe me, you need to develop those all tools around. So I am taking the suture, stay suture just at the junction of bony and the cartilaginous part. Get oriented, okay? This is posterior canal wall. So I'll come out here. If you can show a little bit from this camera also, that is. Can you see from where it is coming? Hello?
Yes, sir. Yes, sir.
Yeah. Otherwise, imagine taking all those post-oral incisions, preparing the periosteal flaps, entering from behind, just for the type 1 tympanoplasty. Or let it be for the other, we will discuss later on. For just pulling, this is a quite big thread they have given, but usually go for the 80 number tonsil thread, or you can go for 20 or 10. Yes, better. Now my two hands are free and I need infiltration. Please make a difference, okay? Everyone knows the different techniques. So how beautifully we can do. You have to make just a difference. Now this is a better picture. In a left hand, there is a suction, so no question of the fogging. Give me the xylocaine with adrenaline.
That ready solution which is available.
Yes, yes, right. Readily available
2%
solution.
with adrenaline.
Yes, with 26, yeah. One in 2 lakhs. That's readily available solution. Okay?
Yeah.
Yeah. So just go. तुमने कितने नंबर का नीडल दिया है? It is breaking, huh? So very thin tympanomeatal flap, but be patient. Okay?
Yes, sir. Yes.
Yeah. Here it will be very thin, so I need to be very, very careful. So I will go from here. Otherwise, it gets torn. See that, okay?
Yeah, that bulge.
Better. Now here. Better.
Yeah, 26 gauge, 1.5.
Yeah, 26 gauge. You have to take care of this flap. Okay, see that's how it is blanching is happening. Okay.
Yes. Sir.
Yeah. Yeah.
Like same flow 4-quadrant infiltration.
Yes.
Do for stapes.
So we will wait for at least after giving xylocaine with adrenaline, at least wait for 1 or 2 minutes. I will use a xylocaine with adrenaline pack. Give the Merosil pack. Instead of those cotton plagiate, I use the Merosil, simple Merosil, what we use for. So instead of those cotton plagiate, use this. Why? Because that cotton plagiates leave some lint there, and that could be the reason for your failure. Okay, give me xylocaine adrenaline pack. Madam,
This Merosil soaked in xylocaine with adrenaline 4%.
yeah, exactly. Yeah. थंब फोर्सेप्स से ले लो. मेरा इंस्ट्रूमेंट में सब कुछ है, आपका कुछ भी मत इस्तेमाल करो. हाँ? और एक हाँ? दोनों निकाला अपने बॉक्स क्या वो सब Hmm. So don't take your all instruments. Huh? One more. So regarding the hypotensive anesthesia, what you need to have is that almost 100 to 60 or less, and your pulse should be less than 80. Then and then only it is nice way to operate on that. So coming out again, I will harvest the tracheal cartilage later on. So discussing just when we are waiting for 1 minute, can you show me some instruments, my angle instruments? So till that time, I will show you the angle instruments. खोलो इसको. सगळे इंस्ट्रुमेंट सगळे हे झाले सगळे. So see this. This is a flag knife. It has bent almost to the 40 degrees. So when you are going and elevating in the anterior wall, so this works like this. Okay. When it will be going into the attic, it will work like this. Okay. So just giving this simple angle. Then again, the angle given for the routine cecal. Because you are working, it's a 6-wall matchbox. So you have to work here anteriorly in the protympanum, then in the retrotympanum, in the epitympanum, then in the hypotympanum. Now it is the overhang is there. So we need to give the other instrument. See this now, okay?
Yes, sir.
Cecal, but it is bent, with the 2 angles. Okay, so working becomes very easy when you are working here. See this how it works. Right. Other angled instruments, so flag knife and I nahi hai Chatrafi. Circular. Nahi hai. Your circular and this bend. 2 bends. Can you see that?
Yes, sir.
So when you are working here down in the hypotympanum, in the protympanum like that, so it will work. That peak, cobra type peak. Three angles. Look at this. Okay.
Yes, sir. Like
so by rotating this, this is for what? This is for opening the tensor fold. Okay, going like this and opening, and even working in the isthmus, that is anterior isthmus, and even in the retrotympanum, taking out the cholesteatoma from the sinus tympani. Okay, got these instruments?
yes, sir.
Yes. Okay. Do you have the O2 shield? Okay. So just after giving the xylocaine with adrenaline, usually the blood pressure is raised around by the 10%. So it has gone up to 100, 110. Now it has come down. So that's why you have to wait. This is a protector. Okay. This is the protector for किसका मोबाइल है बंद करना please. This is a protector for your drilling burr, okay, which has been developed for that when you are working. See this is a protector. So it has got the suction, it has got the irrigation. This only fits to your simple marathon hand piece. So that's all. So the burr will be here. So we will show it later on because there was a 2-minute time. So that's why I just shown it. So let's move forward now. See that even the aeration is through that. I will unpack. So that is how it works. So that's how you can't deny these two hands. Forceps, please. You're not comfortable, sister. Come here, okay? Just see the way I am taking it out. I'm not touching the to the endoscope. So need not to take out that endoscope. These are the small tricks you need to do, and then the surgery becomes a interesting thing. That's all. Better go a little bit in. Give me this sickle. I'm not using the zooming, okay? Still, because if you use the zooming, so this comes quite near to the things. So we'll do that while doing the things. This whole thing will go later on because I'm going to throw it out. That's a tympanosclerotic plaque. Go a little bit in. You can see the overhang there, okay?
Yes, sir. Yes.
Yeah.
This is the first step, like freshening the margins of the.
Absolutely. As such, I'm going to throw that out whole TM because this is a tympanosclerotic, but just as an to show the first graduates, so take that out boldly. There is no problem for that. Suction is there, so that's why there is no fogging. Give me the forceps. See, this is a very thin canal, very thin canal. So you have to be very gentle because you have to preserve that skin from where the squamous epithelium will grow. Take that out.
Yeah, that even that anterior tympanosclerosis patch also came out with that.
Yes, no, it's still there. It's still, yeah, almost it has come out. Now let's go inside and see because I can see the protympanum completely through the perforation. Can you see that eustachian tube?
Eustachian tube.
Yes, and I can see now even the tensor canal.
Yes, sir. Yes.
Yes. Okay.
Superior.
Yeah. So let's go, and we'll take the incision for the circular. Some wash, please, and some xylocaine with adrenaline pack at the eustachian tube. Flush. Please feel free to give this suggestion to the way you do because this is not just as an even I am learning. Okay, this is not what you can call just demonstrating the techniques and all because improvising the steps, it's always an open field and we need to continue it and we strive for that.
And share it only simple saline, sir.
Yeah, this is I prefer ringer lactate, so I have taken the ringer lactate. So in during the corona pandemic, we used to wash it, and still we are continuing that 0.5% povidone iodine, okay? Because we are not knowing whether the patient is carrier or not also. So better to use 0.5% povidone iodine. It's not that ototoxic and all too. And it takes care of give the lot many viruses are killed with the 0.5%. It's now proved beyond doubt. We have just started as an hypothesis, and that paper we published in American Journal, and later on lot many study has been done. थोड़ा मोटा दे रहे हैं जाइले. That 0.5% kills lot many viruses. So use that as an irrigation during the mastoid also, and just you have to put 25 ml of 10% in 500 cc of ringer lactate or the normal saline, and use that as an irrigation. Even I use it for the coagulation and all.
These are the pieces of merocell, sir? Or
Yes, these are the pieces of merocell. Now field is quite good. So typically for again postgraduates, you take a 6 o'clock incision, 12 o'clock incision here, but I have modified. I am going to take almost 270-degree incision. So this is a skin here. I can feel the bone. So bony cartilaginous junction. This is very thin skin. So if I take it here, this will turn. So I'll take the incision here. I will go till now here, and then undermine the. So always the skin is thick to start here in the posterior superior area. Take a time for these steps. There is no hurry, because saving the skin is very, 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 very important. Rest, there is simple steps. Elevate the tympanomeatal flap, and then you have to put underlay graft. If you are doing the underlay, if you are doing interlay, do interlay, whatever. And you, with the endoscope, you will see the difference, how it is more beautiful than the microscope. Imagine you are doing it with the microscope. This area is not there in your picture. And because this is a narrow canal, almost it is not that wide. You can see these overhangs. So always there is a fibrous band here at the tympanomastoid junction. Take time for that. Suction is helping me for preventing the fogging, and another thing, it is cooling the endoscope. Okay, whatever heat issue is there. Yeah. So take time for this step. Okay, I don't have any hurry. So here is some fibrous band. If I want to look, I will just rotate little bit. So the superior part will be in the picture. Okay,
fine.
Is the picture clear there?
Yes, sir. Little bit
still yellow,
bloody.
Oh. Here is really beautiful striker camera with 1688 with very good, excellent monitor. Thanks, Devi, for arranging this. Because it's a luxury to operate with these tools. So take a time for this. There is no hurry, because this is one important step, and later on it's not much big things. You have to just see inside and go for that. Xylocaine adrenaline track again. So I will use, so that will finish. So you can see this suture line.
Yes, sir.
Yeah. Good.
From the suture line, the fibrous bands will be coming.
Yeah. This is a 3 millimeter endoscope. That's why I have at least 2 millimeter space around to operate. And the
Storage.
future, yeah,
Storage.
it's a storage. Now we have created our own brand also, and
Length, length same nasal.
no, it's a that is what the, because the storage has got only 14 centimeter length, and that is not sufficient, you know. But for the single-handed people, they are happy. But for the two-handed, we need 18 centimeter. So that's why we have created that scope with a brand name called E scope. Huh?
Longer one. Longer.
Yeah. That's better now. Arnold's nerve. Can you see that?
Yeah.
Yeah, this one. Okay, coming from here. See this? Huh? Yeah, I'm cutting that. So go a little bit near. I am keeping endoscope at the isthmus level.
Endoscope is not touching any wall of like.
Yes.
There are issues, sir. If it touches, that heat is transmitted to the skin.
Nothing. It's hardly, because that's what I'm telling you. Because whatever you are using this suction, huh? That is vapors are taken care with this. Thousands of ear surgeries we must have done with this two-handed technique. Hardly it has. I have not seen any single case of burn and all. Only thing remaining is that we have to measure that temperature, how much it is with the endoscope, and then how much it is reduced with this suction. Give me the irrigation little bit. Always there is a bleeding from here. Huh? That is the lower part. Intermittent irrigation helps you to take care of the hydration of the tympanomeatal flap and the surrounding structure too. So go a little bit near. Yes, that's good picture. Just 1 millimeter of movement. Okay. Give me the circular again. See this, it's an overhang here.
Yes, sir.
And always, sometimes bleeding is there, no problem. You can use even the suction cautery, small suction cautery. Yeah, better. Let's go from above. See, if you measure the canal width, it's not more than 6 millimeter here, okay? Because whatever your circular is only 4 millimeter. So just see how much it is. Circular plus one suction tip, 6 millimeter only, this canal. I have reached the annulus.
Annulus, yes.
Yeah. So now little bit theory. If you keep the annulus down and the fibrous layer and elevate only the squamous epithelium and you put a graft in between this, that's a overlay. If you elevate the annulus along with the squamous epithelium, keep the mucosa down, that's an interlay. But classically it cannot be done. That's why you can take out this annulus just for the, and when you elevate whole of the TM, that is all the 3 layers, and put a graft underneath, that's a underlay. So go a little bit down. Can you see the plane?
Not that clear, sir.
Not that clear? Okay, we'll go a little bit in because,
Color is little bit changing.
I'm sorry for that because I can see this. See this here. Here is the annulus. And we will go from here. This is a bony part of the annulus entering inside.
Yeah, that we can.
Okay.
Yes, that we can appreciate.
Yeah. Chorda.
Yes, chorda is.
I have elevated classically underlay. Okay.
Yes, sir.
Yeah. I can see the incudostapedial joint here. Can you see? Appreciate
Yes,
that?
yeah, yes.
Okay. Go down. Now my instrument is not reaching there. So you need those angled instrument, bent instrument. Okay. Let's put some, I will unpack here and then we'll elevate from above. Coming from up, some irrigation. With the endoscope, only problem is this depth perception. You may be feeling very wide canal here and so big canal, huh? But it's not. When you are operating, you come to know.
See, one more advantage of this irrigation is all the smaller blood clots and all will be washed off.
Perfect.
Your field will be like looking fresh.
Yes.
And in between, keep orienting all residents like superior, inferior, anterior, posterior. Because by the time you blink your eyes and look into the picture, you will lose the orientation.
Yes, a little bit. Because I have touched, it's give me the clean the endoscope. If blood is also got the thing, just a normal saline cleaning. Tortuous canal. Okay.
Superior, inferior, anterior, posterior.
So this is the superior part. I am going from here. I am opening the Prusak space. Prusak space laterally bounded by the Sharpnell's membrane, medially by the neck of the malleus, and then down the lateral process of the malleus. Give me the cecal. So this bone I am going to remove it because it's a very this posterior superior overhang is there, so that we will be able to see the retrotympanum.
Like a ridge it is. That is the extension of tympanomastoid suture line.
Yes. Can you see the neck of the malleus?
Yes, sir. Yes.
Now this is a lateral process.
Lateral process. Yes.
Going down, I have gone into anterior superior area. This part, okay. Now I need an angled flag knife. See, this whole instrument is only of this length, so 6 millimeter only. So from here, see how it works. This works like this, okay? And you are able to elevate and undermine this graft, sorry, tympanomeatal flap. This is the area of your tensor fold. We will go and see later on. Okay. First, we will elevate. इसको आगे डालेंगे. Now you can see nice lateral prominence of the lateral process. Now we will denude the malleus because I keep the graft over the malleus. See that distance between the handle and this only 3 millimeter. See this is only one flag knife distance. Go a little bit near. Give me the sickle. Get oriented again. Lateral process. Handle of malleus.
So this is
I'm
lateral
denuding
process
the
handle.
yeah, this is this. And I'm denuding the handle of malleus. See that? I can see a beautiful plane here. I hope you
Yes,
are
sir.
appreciating.
Yeah,
Huh?
yeah, we can, sir. We can.
Yeah. I am incising the periosteum. So beta. Many of the time this fibrous layer is quite tough, but take a time to take it out, because if you are keeping the graft over the malleus, the all squamous epithelium needs to go. So I will use some forceps to peel it off. Don't hold the malleus and pull. This is all about looking at the, see that, huh?
Yes, sir. Near the ambo. Ambo it's
Near the ambo, yeah. Now we'll just incise anteriorly, give some flush. Sickle. Unnecessarily don't touch the flap with a suction. If you are touching, control it with your left fingers. I'll go a little bit near. Just a little bit cleaning. In tympanosclerosis, many of the time, it's always a mobile. This is malleus is hypermobile because due to the tympanosclerosis here, some process is going on. I've noticed always there is some hypermobility. So just hold for this. We'll take this out and then later on we will go for taking this out. Let's go a little bit more near. I want to cure it because I don't have a space to operate there. Huh? I'm just taking out this fibrous layer. Okay. Take a time, take a time. There is no hurry. We will remove that. I will unpack. Come out, come out. This is a movement with the fine focusing system, that's rack and pinion. Okay, better. Some irrigation. And then we will take out this bone. See again the angle given for the curate.
Yes, we can appreciate.
Yeah. We will go a little bit near again. Just engage and rotate. Many of the time, you have to try to protect the corda just to see the whole incus. Okay.
Yes.
And in the temporal bone dissection, these things you need to do the surgical exercise. And this is the way you can remove the posterior superior overhang, and even you can go on removing this with the drill tool. Why to take this out? Because many of the times the granulations are there. You have to see in the retrotympanum whether there is something. And here it's quite a big overhang. So even the chorda is hidden. So take that out. But make sure that this movement will not be there. Okay. Otherwise, ossicles are damaged. Always it should come out. Some flush again. Still, I have to elevate the flap downward. Curate.
Now the card is seen clearly.
Yes, that's why, because it was not able to, I was not able to see that. That's sufficient for me. Okay. That's better. Now I can see the incudostapedial joint better. Just a sickle. We'll remove the that's an annulus. We'll take out that. Okay. Just remove this some mucosa. Okay. Incus. See, it's an hypermobile. Huh? Okay. Now
It's the incus and incudostapedial.
incudostapedial joint. Okay. So we'll take this out. This is the part of the annulus. Circular. Now, flag knife. I want to elevate, and then I will take out the whole thing over the malleus. Okay, I'm just undermining here. See this, I'm taking out this whole flap from here.
Yes.
Do you appreciating that?
Yes, sir. Yes.
Yes. So almost I can see here, you can appreciate round window niche, fustis, okay, hypotympanum.
Yes, this is the
Okay.
round window niche.
Yes. So I have not gone here, I am undermined here so that graft will go nicely here. Better. Go a little bit in. Yes. One more flush and then we will elevate from above. Angle. Suction is blocked. Normal saline. I'm going slowly to understand all the steps. The second case will be directly, you can go and do the things, okay? Even you can wash the endoscope to cool it, okay? There is no harm. That's all. Coming to the single versus two-handed, because it's a ease, because you have learned all your surgeries with the two hands, and it becomes very easy because you have a panoramic view in front of you. You will not miss anything. Normal saline. So let's go down here. Just washing the endoscope. Wash. Endoscope. Okay. If you put a normal saline on the endoscope, picture will be clear. That's all. So go down to elevate again. So downward. So you be patient to take this out, everything. There is no hurry.
Near the umbo, the fibrous tissues will be very tough to.
Tough, exactly. Yeah, so that's what I'm telling you. Be patient for that. Time लगेगा, लेकिन जल्दी किधर है, थोड़ा सा इधर उधर हो जाएगा. Anesthetist will put a little bit more charge. There is no problem. Yeah. Better. Yes. यहाँ पे we repose back. We will take out that I will unpack. Then that flap will go there and we'll pull it. Let's go and see. Someone I will unpack is still there. So I'm almost elevated this here, but I am going to take that out. I will going to cut that. Okay, that tympanosclerotic plaque I don't want. Caesar. This is an iris Caesar. Out. थोड़ा सा इसको भी निकाल देंगे. Take care with the suction, okay? Because that's a dangerous things. It tears off everything. Better. Can you see now this good, beautiful picture there?
Yes, sir. Clear.
Yes.
Clear. Here we can
Little
see.
bit of some tag over the umbo. I'm going to take that out, and then I will undermine all the things that's anterior wall. Here is always you have to overcome this depth perception problem. Okay, you need not to hold that. See that? Okay.
Yeah, clear.
Yeah, it is come out.
Yes, sir.
But you should not hold the umbo.
Yes, yeah.
Yeah, chalo. Looks good. And now little bit inside, and then I will elevate the anterior part. That's a little undermine there for the graft. I need an angle circular. Tympanosclerotic plaque is there. I'm going to take that out. Okay. I need a angled circular. So you need to first incise the mucosa here and then elevate. Okay.
Yes, sir. We can see. That's near the eustachian tube.
See this. I'm elevating this flap. Okay.
Yes.
I'm going to come from here because it's going inside here. Okay. So I have to be sure. Better. Yes. And now one wash again. And that one tympanosclerotic plaque is there anteriorly. I will take that out. Force him. Flush. Take care of your suction, okay? And even when you are doing this irrigation, even water, if it is in crystal clear, if it is not mixed with the blood, that acts as gives a zooming effect, okay? And there is an underwater surgery too. Okay, better? Right. So again, go back and elevate this and give me the circular. I have to elevate that here. So we'll go a little bit near and elevate there. Then the inferior part. Give me the angled flag knife. Flag knife. I'm working on the bony annulus in the inferior part. Any suggestion, any questions?
That's you are doing that step to put the graft there.
Yes, yes, exactly. That looks better now. And let's go here. Thoda, I'm not happy for the malleus. तो थोड़ा scrape और करेंगे. थोड़ा सा clean. Lucky rest, my job is to harvest the cartilage and put a graft and see in the middle ear. That's all. Give me the seeker. It's looking better now. Now the whole middle ear is in your panorama. We will see. We'll go and do the middle ear endoscopy. इसको आगे ढकेलेंगे. Let it put there. Better. So नजदीक जाएंगे थोड़ा. Oh, that's good picture. थोड़ा section छोटा. If at all, if it's too difficult to take it out, many of the time I just use the malleus nipper and cut the umbo. Suction size थोड़ा सा बड़ा है इसके लिए. छोटा दो. निकल जाएगा वो. So just be in that plane. I'm supporting the malleus. Instrument needs to be very sharp. If it is not, it gives a trouble. There is no problem. It's a fibrous layer, need not to worry about, but I am little bit more careful to take this out. Okay, now forceps. And it is hypermobile, so I need to be very, very careful.
Yeah, anyhow, you are exteriorizing it also. No problem. Nothing to worry.
Yes, sir.
Anyhow, it will be exteriorized. No, that will not be a problem. Even if you leave it there, I think it will not be a problem.
Yeah. Now I keep a graft over the handle of malleus, so that's why better. Yes. थोड़ा सा wash. Yeah. चलो थोड़ा middle ear endoscopy करेंगे. We'll harvest the cartilage. Normal saline.
Yeah, just once orient, sir, for the sake of
Yes, definitely. Block. थोड़ा सा काढ़. Ball point. Take care of this suction. Suction is a very dangerous instrument. If it is not of proper size. So you have to be. Oh, you can see such a big anterior isthmus. I can see. I will show you the whole anatomy. Then it will be. Okay. So now getting oriented, little bit coming from above. Anterior wall, posterior wall, superior wall, inferior wall. What is the first structure which is striking? Is nothing but the handle of malleus, lateral process of malleus, neck of the malleus. The things which is going like this, perfectly like this, is a chorda tympani. It is getting originated here, usually gets originated in the stylomastoid foramen and goes like this. So actually this is the boundary for the facial races. Okay. So what are the structures? From the distance you can see is a malleus, incudostapedial joint, and then chorda tympani. So let's go a little bit near. So once you are near, put a suction in so that fogging will not be there. Beautifully, I can see, get oriented again. This is a part that's an attic. Okay. This is an anteriorly, there is anterior tympanum. This is a posterior tympanum. This is a scotum. Okay. So now area between these, can you see that it is going inside?
Yes.
Okay.
Yes. Yes. Sir.
That is an anterior isthmus. 80% of the ventilation to the mastoid and the posterior tympanum goes from here. The whole thing that comes from the protympanum to the mesotympanum, from here, 80% it is ventilated from here, and 20% will be from here. That is a posterior isthmus. Okay. This area. Okay. This area, you can see that small fold there. Can you appreciate that?
Yes, sir.
Oh, it's beautifully seen. Can you see that white thing? Okay.
Yes, anteromalleolar.
So that is nothing but the tensor fold. In 75% time, this completely closed. If 75% is closed and 25% accessory small opening is there. So the ventilation from here comes to this. So many of the time you can open this. I will show you how to open this. This is nothing but a supratubal races. Down you can see the tensor canal. Okay, for the tensor tympani.
Yes,
this is supratubal races. It leads to the tensor fold. If you open it, it will go to the anterior epitympanum. Okay, so this perfect landmark. The attachment here is a tensor tendon. So let's go and see the tensor tendon. Can you appreciate that? Let's see.
Yeah, that white band.
Yeah, let's see. We will go very near. Otherwise, you need an angle endoscope. But this is I am using with the 0 degree only.
Processus cochleariformis and.
Yeah, I can appreciate the tensor. Huh?
Yes.
Can you see that? Oh, beautiful. I can see that. But any anterior isthmus too. The blood is collected in anterior isthmus, and I can see the processus cochleariformis. Give me the small pic. Let me go. Just see down there. Okay. कुठला दिला रे पहा नाही स्ट्रेट दे वाकडा कुठला दिलाय स्ट्रेट पीक दे फक्त एकदा very beautifully I can see that tensor tendon, and just behind that there is an anterior isthmus. Keep your eyes focused in between the malleus and incus. Straight this.
This is malleus and this is incus.
Yes, see
So
this.
here you
Now,
can see the
because I'm
process
very
of
near,
operating.
this is malleus, incus, incudostapedial joint, processus cochleariformis, okay? And
Yeah,
this is
clear.
a tensor tendon, okay?
Yes, sir. Very clear.
Can you appreciate that?
Yes, very much.
Okay, and this is nothing but the anterior
If you
isthmus
can
opening.
little bit do suction there. I
Yes,
think,
because oh, that's
little fine focusing can now the handle of malleus is focused. If you focus it to the depth, yes,
little bit focusing because you are very near.
yeah, okay, sir. This is processus cochleariformis and this
Oh,
white
that's
band is
beautiful
the
now.
tendon. Yes.
I will go a little bit near because I can't put instruments, but you can go and appreciate that. See that?
Yeah, clear.
Okay. Yes. Let's go. Even you can see the tensor. Sorry, stapedius.
Yeah, this is stapedius tendon.
Please show there. Okay, it's a
Yeah, I
stapedius.
am showing, sir.
Yes, it's a stapedius. Nicely seen.
See.
Okay, come again back. Little bit wash and then we will just see round window knee. So you already appreciated that. I'm not able to appreciate the Huh. Huh. Huh.
Patient tube opening.
घेऊन टाका, सुरू करून टाका. ते डायरेक्ट हो, कारण हे डिटेल मध्ये दाखवलं. हा हो का? ओके, ठीक आहे. हॅलो हॅलो.
Yes, sir. Yes, sir.
Okay, because this is an important thing I'm showing you, because this is, so look at this angled peak, and I'm putting it in the tensor fold, and it is just opening. Okay.
Fine, fine. Sir.
Okay. See that.
Yes, yes.
Okay. It's entered into the anterior tympanum. See that. So just open it, like the way you widen the maxillary sinus ostium. Okay. It's going inside. Okay. That's sufficient. So let's go for the harvesters of the cartilage. Already it's more than 1 hour, 2 hour, I think. So in the next case, we will see much more things what is not there. Only thing is, the idea is to see the concept of two-handed endoscopic here surgery, how beautifully it can be done. Okay. And believe me, the budding ENT surgeons do much more job very nicely, and they are very fast to learn these things. Clean this endoscope and when the endoscopes are there lying in your OT, when you have excellent cameras in your OT, yeah, why not to extrapolate it, have some another tool and carry out the beautiful endoscopic here surgery. So let's harvest for the tracheal card. तो आज दिलंस काही टाइम एक पॅक दे अजून वन मोर पॅक. So harvesting the tracheal cartilage. So by keeping the 5 millimeter of dome, hold this with some forceps, protect this. I hope you are able to appreciate.
Yes, sir.
Yeah. So hold this and go through and through. One stroke, go inside skin and the cartilage, deliver it. And then go till the incisora. Harvest as much as
you
possible.
Infiltrate, sir?
Yeah, already I have infiltrated.
To the tragus.
To the tragus. Here you have to infiltrate. Yeah. Suction. So dissect it. I'm looking at the monitor, and this is the best way to learn develop the skill. 2 hands, hand, eye, and monitor coordination.
That is why youngsters do better, sir. Because
yes,
play with this video games.
Perfect.
Hand-eye coordination is very good.
Perfect. You are perfectly quoted the example. So we should ask our resident to play some good Xbox videos.
They were grown up with that, no, sir. We have not done that. That's
we have
where
not done.
struggle.
We didn't had anything, you know. Even I don't know a
No
simple
boxer.
ABC of these all video games. Clean it. Clean it. Endoscope. So that's what I told, because the newer generation can do much more things for this endoscopy, and lot many things, improvisations are going on. Artificial intelligence is entering. Okay, so because one day the things will be in the monitor. The message will be go on going. No, don't do this. Now go here. Okay, you are here. You are going to damage this. You are near to this. This possible. This is called endoscopic navigation. You have well versed with the what you can call the navigation in the nose, but this can be possible. That's called artificial intelligence, and sooner or later, definitely it will come. And the teaching, learning will be very easy, and even the complications will be very less, because when things are alerted, the novice surgeon will do a very less mistakes. Means alarm will be sounding. Oh, you are reaching the facial. Stop, 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 stop. Okay, like that. So instead of being a dogmatic, instead of being fighting with what is good, what is no controversy, see the advantages and just go ahead. That's all. Because we need to simplify our life. Yes, that's better. Now, even I can harvest the perichondrium here, but there is no need. I will peel it off. I will show you how I do it.
So you don't include the perichondrium in your this thing.
Yeah, no, I will take
cartilage.
Full cartilage. I will harvest. Then I will take out the perichondrium on one side, and then I will use the excess graft.
One side perichondrium will be harvested.
One side perichondrium will be harvested. On one side, it will be kept. Give it season, small season. Because perichondrium is very much necessary for the nourishment of the cartilage. So you have to keep on one side. Always there is a lot of connective tissue here. No problem. Take a time to harvest. Sometimes even a bleeding comes here, but that's not as an torrential bleeding suction. Just some small vessel.
Any parameters are how much to harvest or like?
Yes, usually now here I don't need much, because already I have calculated while doing the dissection only. Yeah, I need some 8 millimeter by 8 millimeter here. Otherwise, for when I am doing the total perforation is there, and whenever there is a big canal and I need some reconstruction also in the attic, I harvest 1.2 by 1.2. Here I will not harvest that much. Okay.
Okay, sir.
Yeah. So this much we can see on a grid. So around inner length around 1 point, this is 1 centimeter. You can see this is a grade. So 1.2 and this is 8 millimeter triangular. Give me the thumb force or the scissor first. We'll take this out, all the connective tissue. I will keep this perichondrium. I will take out this perichondrium. Okay. So whenever I will be using the cartilage, so the cartilage not having the perichondrium will be facing toward the promontory. So over the long period of time, what happens? Many of the chondrocytes are lost and this graft becomes thin. That is one concept. And another thing, if when you are taking out the perichondrium on this side, so 0.1 mm you are taking it out. All these surgical exercises the residents must do, although it looks simple, but that improves your surgical skill. And this is the bread and butter surgery, so must do it in precise manner. Caesar. Even whenever there is a attic reconstruction, I keep this flap and I will use as an island graft. Okay. Okay. Even you can use it for the reinforcing. If the small perforations are there, only perichondrium can be used. I don't think I need here. So Caesar. The other case can be induced, okay, because I have taken a little bit time. Thumb force. So this will be kept in the graft press. Now see, it's almost a thin, almost a 0.8 mm. So I'm not going to slice this cartilage. If it is a quite thick one, more than 1 mm, then I usually slice it. So let's make an island here. Here is the slicer. This is not just a slicer. This is for many things. Yes, sir. So you can see this slicer here. It has got the creed and even for the slicing. So for what it is, you have to create the island here. So now you see this. This is more than 10 mm by 10, okay, 10 mm. So I will be creating the island here. Cartilage card. Cartilage is atla card. No, je tukde. Don't put that full thickness graft, because full thickness graft usually gives some tinnitus and even some blocked ear feeling. And another thing is that the cartilage survives for a long, okay? So this, if you do the cartilage tympanoplasty like this, over the period of time, you will see a very thin graft like as an TM fascia, only it will look like as a mild tympanosclerosis type, because the cartilage go dissolve it later on if you remove the perichondrium on one side. So these are created for the different type of different shape perforations. So I will make a V here. Better. This will come and lie over the bony annulus. Okay, perfect disc. So it is not just cartilage, tympanoplasty is not just harvesting the cartilage and just putting it, that's all. But you have to sculpture it nicely, okay? Then it gives and good results. Better. So now I will create a V for accommodating the
Handle.
yes, malleus. Okay.
Clear.
Now when such cartilage is there, this very small cartilage, okay, you need not worry that you are pushing something and gives a good result, believe me. Now for the it's a decade, more than decade, we are doing the cartilage tympanoplasty in different shield grafts, islands, palisades, so many things, okay? Slicing, better. So now this is ready. Let's go and put the graft. Just one stitch here. Give me. And dry the gauze piece, dry gauze piece, and for the soldiers, army, army doesn't still accept the cartilage. So because lot of CRPF camps and DODs are there in Pune, so many people who come for us, they ask for stitchless and they don't want a cartilage. So what we do, we harvest the temporalis fascia from the hair, from the temporalis fascia through the hairline incision, so the incision is not seen, and then it perfectly becomes a stitchless surgery, okay? And transcanally, you can go for the suction kartas. And even this scar will not be there. But believe me, over the period of time, this is not seen at all. Unless and until you damage that dome of the cartilage, and some infection happens. Otherwise, healing is super fast in such small incisions. So again, I'll tell you, you have to do all these things at looking at the monitor to improvise your skill. Okay. I think they have given a Vicryl, need not to take it out again. And a 40 or a 50. Sufficient. इसको रखो, लगा तो ले लेंगे, but right here. So just clean a little bit the endoscope. Force it. Wheat आणलं नाही आपण, wheat. Again, going from down, from up to down. Good, clear middle ear. These are some small aberrations, need not to worry for that. Anterior wall, posterior wall, superior wall, inferior wall, tensor fold area, anterior isthmus area, posterior isthmus area. You can see the round window niche down here. Incudostapedial joint, eustachian tube here. So I will put the graft, okay? And let's go fast for that. Graft, please. Any question?
No, sir. No.
Oh, so you need to clean this because this is not. We don't want any dirt. Circular. This is from the instrument, okay? So take that out. There is no problem because as such we are going to. And many of the times there are the hairs, okay? See this, can you see that hair?
Yeah.
So take that because we have not cut completely the hair. So we apply wheat for that. So usually those hairs are from the skin. So take time, there's no problem. All small things gives you a good results. The instrument covers better. This will go like this. Better. Force. So keeping the endoscope here and going inside and then take the endoscope in. Cecal and suction. Where is where your V? V is here. Okay. So this will go like this above the. Just go a little bit in. Because the canal's size is very small, so you have to adjust it. If it becomes a big, I will take it out and again put, but I think it will fit. You have to rotate. It will go down and this will fit like this perfectly. Okay, it's a perfect size. See that? Okay.
Yes, sir. Yes.
Yeah, and this will line the canal wall like this. Okay.
Yeah.
So let's see and adjust anteriorly. Ballpoint. Suction again needs to be very, you have to use suction very carefully. Now some Abgel, some soaked with many of the time it's curled here, so you have to revert back. And suction has to be controlled very well and use Abgel here now. So that looks a perfect disc. Can you see that? It's perfectly fitting. Okay.
Yes, sir. Clear.
Now just I will use some Abgel and then crystal clear I will show you. थोड़ा सा मोटा. Use Abgel soaked with the simple normal saline so that you can perfectly line that. I have to little bit adjust it because this flap is, see this flap is gone inside, so I have to take over it. Better. Suction मोटा है. Change the suction. Abgel. You have to adjust nicely here because this flap is here. Take a time for that. There is no hurry. That's better. This flap we have to see whether it is, yeah, see that's a everted there.
Yes, clear, sir. Clear.
Yeah. तो इसको थोड़ा सा इसको ठीक से बिठाएंगे and then come back again. That's better now. And then we'll adjust this. You have to support.
You soak gel foam with any?
Yes, some antibiotic soak, but here you're putting some antibiotic. What antibiotic you are using? Okay, ciprofloxacin. They have soaked that, huh?
Okay.
Yeah. So meticulously repose back this flap. See above. That's it. Just see whether it is fitting nicely or not. See that our cartilage is here and that is perichondrium. So perichondrium को पीछे ले लो ऐसे. That's better. And then again back. आपसे. So imagine doing all this single type 1 tympanoplasty. You can do it with the single hands. There is no problem. But try comparing if at all, if you want to drill it more and the way, the ease of doing the surgery. Obviously, the learning curve is needed for everything. Clean. I think you can.
Any questions from the audience?
Yeah, please, because otherwise I'm handing over the case to Dr. Sapna so that I will come down and start the lecture because it's already late. So just adjust it nicely.
Yes, sir.
Any question? Let it come. And
Yes, sir. Very nice,
Okay.
sir. Thank you.
Yes.
Thank you very much for nice demonstration.
yes,
It was
thank you.
very clear.
Yes, thank you very much. Still, we will then the different 3-4 cases are there. So we will see what we have not seen in this case. We will try to see in the other case. Okay.
Fine, sir.
Yeah.
Thank you.
So thank you very much.
Thank you so much for the demonstration, sir. Thank you, Dr. Jyoti Swarup, sir, for chairing the session. We will now have a small tea break for 10 minutes. Kindly proceed near the registration counter for the same.
तुमची दुसरी केस इथंच घेणार आहे का? मग हे तिकडे लावा. तोपर्यंत